3:47 a.m. The patient is Gray, 48 years old, a high school football coach. 4 hours ago, he was at his daughter's wedding rehearsal dinner. He felt a pressure under his sternum at the steakhouse. His wife drove him to the emergency room. His EKG shows ST elevations in leads 2, 3, and AVF, inferior wall. The fluoroscopy screen above the table shows the right coronary artery cut in half, 100% occlusion at the proximal segment. The Cath lab clock reads 43 minutes since he hit the door. The wire is in your hand, 0.014 inches in diameter, thinner than a strand of hair. The next 90 seconds decide whether his daughter dances with him at the wedding tomorrow. You advance the wire. This is interventional cardiology. Level 1, medical student, negative $212,000 in education debt. Third-year cardiology rotation. The Cath lab is on the second floor. You're standing in the back with the curtain pulled. The attending is working a 58-year-old with stable angina. He injects contrast. The coronary tree lights up on the screen at 30 frames per second. Branches you've memorized from Netter coming alive inside someone's chest. The vessels you drew on flashcards last year now pulse in real time. For the first time, you understand what blood pressure actually is. The fellow next to you whispers what they're looking at, a 70% stenosis in the mid-LAD. The attending says he's going to stent it. Frank Sinatra plays through a portable speaker on the equipment cart. You can't read the screen without help. The fellows speak a language you don't recognize yet. LM, LCX, FFR, ostium. The wire on the back table is 0.014 inches in diameter, thinner than a strand of hair. You don't see how anyone could thread it into something the size of a piece of cooked spaghetti without rupturing it. You go home and pull up the Cath report from the Sinatra patient on the EMR. By morning, you have read every Cath report from that day. By the end of the week, you have read every Cath report from that month. In December, your mother visits for the white coat ceremony. She frames the program. You don't tell her you have not slept 4 hours a night in 6 weeks. The cardiology rotation ends in March. You apply for internal medicine because internal medicine is the door. 3 years of residency, then the fellowship match, then cardiology, then interventional cardiology. If you're good enough, 7 years before you're allowed to stand at the table. You don't know yet that in 8 years, you'll be the one holding that wire. You match into internal medicine. Level 2, Intern, PGY1. $65,000 a year, national mean. Hospitalists you went to college with are making $300,000. 2 a.m. You are post-call on the cardiology service. 11 patients on your list. The pager goes off. It's a nurse on the cards floor. Mr. Jackson, 83 years old, post-op day 3 after a coronary artery bypass. Potassium 6.4. You order Kayexalate. You order an EKG. The EKG comes back with peaked T waves. Calcium gluconate. 10 units of regular insulin with 1 ampule of dextrose. The orders go in. You walk to the floor. You watch the EKG settle. The repeat potassium drops to 4.8 at 3:47 a.m. You document. You go back to bed for 45 minutes before the next page. 26 years old. The most junior person on the team. The nurses have been doing this for 30 years. They know more than you. They watch you write orders you don't fully understand, and they wait to see if you'll catch the mistake. The first 6 months are survival. You hide nothing. You ask. Every miss goes into a black notebook in your white coat pocket. In September, you almost miss a pulmonary embolism. The patient is 42, post-cholecystectomy, complaining of shortness of breath. You order a chest x-ray. It looks clean. The senior resident pulls up next to you at the workstation. He glances at the vitals. He orders the CT angiogram. You hadn't thought of it. The clot is the size of your thumb. The senior resident does not say anything to you about it. You write it in the black notebook. In November, you make a different mistake. A 55-year-old with chest pain and a clean EKG you send home. He comes back 12 days later with an NSTEMI. You write that one in the notebook yourself. By month 7, the pages stop scaring you. By month 9, you can recognize a sick patient from across the hallway. 80-hour weeks. You drive home at 6 a.m. through empty streets, and sometimes you are not sure how you got home. You don't see daylight in winter for 3 weeks straight. In the third week of January, you write your application for Cardiology Fellowship. Level 3, Cardiology Fellow, PGY 4, $80,000 a year, 3 years of fellowship. By the time you finish, you'll be 31. A third new city since college. The lease on your apartment is 1 year. The walls are still empty. Your fiancée is finishing her fellowship in a different city. You see her every other weekend, 2 flights a month. You read Echo on the plane. The Cath lab is on the second floor, the same kind of Cath lab where you stood in the back as a medical student 5 years ago. Now you are on the table side of the curtain. The attending hands you the guide catheter, 5 French, pre-shaped to engage the left main. You scrub. The radial artery access is a small needle stick at the wrist. You thread the catheter up the brachial, the subclavian, into the aortic arch. You engage the left main coronary ostium. You inject contrast. The LAD, the circumflex, the diagonals, all of it lights up on the screen. The same image you watched for the first time as a student. This time it's because of your hands. The attending says, "Good engagement." That's the praise. That's all you'll get today. You speak the language now. You don't speak it like she does. The wire still feels alien. The catheter pushes back when you don't expect it to. You almost lose the guide twice that morning. The attending says you'll get it and walks across the lab to scrub for the next case. 67 clinical hours per week. Hospitalist friends from medical school are making 3 times your salary. 3 years of fellowship. You rotate through the CCU, the Echo Lab, the EP service, the imaging suite, the Cath Lab, and outpatient clinic. By the end, you will have done 250 diagnostic angios under attending supervision. In year 2, you spend 3 months in the CCU running cardiogenic shock cases. Patients on Impellus, on balloon pumps, on 3 pressors. You learn what a heart in failure feels like in your hands when you're doing chest compressions. 2 of the patients you take care of in those 3 months don't leave the unit. The wire starts to feel like an extension of your hand. You don't know yet that in 3 years the attending behind you will not be there. Year 3 of fellowship. 5 fellows in your class. You apply for the Interventional Cardiology Fellowship. 1 slot per program, match rate under 60%. You match. The fellowship begins in July. You will be 33 years old the day you walk into the lab. Level 4, Interventional Cardiology Fellow, PGY 7, $75,000 a year, the 4th city since college. 12 months in the Cath lab, 5 days a week, plus STEMI call. The apron is 15 pounds. You put it on at 7 a.m. and you take it off at 6 p.m. By month 4, you stop noticing it. The Cath lab team knows your name by week 2. The scrub tech remembers your glove size. The radiation tech sets your dosimetry badge to your collar without asking. 2 a.m. activation. STEMI alert. The patient is 62 years old male brought in by EMS 40 minutes ago. EKG shows 2 mm ST elevations in V1 through V4, anterior wall. You are the primary operator tonight. The attending is standing behind you, scrubbed, hands at his sides. Right radial access. The guide catheter slides up the brachial, finds the left main coronary ostium, and you inject contrast. The left anterior descending is 100% occluded at the proximal segment, the widowmaker. You take the wire, 0.014 inches, and advance it through the guide. The attending watches the screen. He watches your hands. He says nothing. The wire reaches the occlusion. You torque the tip. The wire searches for a microchannel. The way water finds the smallest gap in a wall. You feel the tip catch. You feel it move forward. The wire passes the occlusion. You inflate the balloon to 6 atmospheres for 30 seconds, then deploy a 3.5 by 20 mm drug-eluting stent. The ST elevations on the monitor fall back to baseline as you watch. The patient says, "The pain is gone." You write the note. You go home at 5:45 a.m. 3 weeks later, you take a chronic total occlusion case, 63-year-old man. The right coronary has been 100% blocked for 2 years. He has been having angina on a flight of stairs every morning. You wire toward the proximal cap. The wire bounces off and slides down the vessel. You reposition. It bounces off again. 20 minutes pass. The attending watches the screen. 30 minutes pass. Your right shoulder hurts under the apron. At minute 36, the attending takes the wire from your hand. He scrubs in. He crosses the lesion in 8 minutes. He scrubs out without saying anything to you. You finish the case, you write the note, you go home at midnight. You don't sleep that night. By the end of fellowship, you will have done 250 therapeutic procedures, STEMI. Call comes every other to every third night. By March, you have the caseload. By May, you almost have the confidence to match it. You graduate afraid of choosing between a 3.0 and a 4.5 stent. Afraid because for 12 months the attending was the one making the call. The 90-minute clock starts now. Door to balloon, 90 minutes from the moment a STEMI patient hits triage to the moment your balloon inflates inside the blocked artery. Every minute past 90 is heart muscle that doesn't come back. You graduate. You sign your first contract. The hospital hands you a pager and tells you the Cath lab team will know your number by Monday. Level 5 junior attending. $700,000 a year, MedAxiom's 2024 median. The amount you have been waiting for since you were 22. You buy a house. The mortgage feels small for the first time in your life. Your wife frames the photo from your white coat ceremony and hangs it in the hallway. 2 a.m. activation. STEMI. You are not a fellow anymore. 14 miles from your house to the hospital, you drive. Speed limit 60 on the empty highway. Your wife was already awake when the phone rang. She has been waking up to this sound for 10 years. She does not ask anymore. The Cath lab team is already scrubbed when you arrive. You scrub in 9 minutes. The apron goes on at 3:23 a.m. The weight comes down on your shoulders the way it has every night for the last decade. You stop noticing it before you reach the table. The patient is a 71-year-old grandmother. Anterior STEMI, 100% LAD occlusion, the widowmaker. There is no attending behind you tonight. You wire the lesion. The wire crosses on the second attempt. You inflate the balloon to 6 atmospheres, then deploy a 3.5 millimeter drug-eluting stent. TIMI flow goes from 0 to 3. The ST segments fall. She squeezes your hand on the way out of the lab. She tells you her granddaughter just turned 6. You write the note at 5:40 a.m. You drive home. Your wife is making coffee. Tuesday morning is elective. 3 diagnostic angios on the schedule. The first patient's coronaries are clean. You tell him in recovery. The second has 3-vessel disease. You refer him to surgery. The third you stent in the LAD. By 11 a.m., you have eaten half a bagel. Friday is clinic. 23 patients, pre-op consults, post-stent follow-ups. A man who wants to know if he can fly to Ireland next month with 2 stents in his LAD. You tell him yes. His wife cries. Your daughter's 7th grade soccer game is at 6 p.m. on a Thursday. The STEMI page comes at 5:15. Your wife films the goal. 2 nights of call per week, 1 weekend per month. When something goes wrong on the table, coronary perforation, no reflow, a patient who codes, there is no debrief. You re-scrub. You finish the case. You write the note. You return to the list. By year 3, 2 of your colleagues have been named in malpractice claims. In year 3, you lose a patient on the table. Mr. Sanchez, 59 years old, a landscaper, father of 3. Cardiogenic shock from a multi-vessel infarct that started 12 hours before he came in. He thought it was indigestion. You put in an Impella. You wire and stent the proximal LAD. His blood pressure won't come up. You wire and stent the circumflex. His blood pressure won't come up. You call the surgeon for emergency bypass surgery. He looks at the screen for 15 seconds. He says it is too late. You finish the case. His wife and 3 children stand up when you walk into the waiting room. You drive home at 4 a.m. You do not tell your wife about it for 6 months. Your daughter starts kindergarten. Your son is born. The grandmother sends a Christmas card every year. The fellowship director who trained you turns 60. 5 years pass. Level 6. Senior operator, structural heart, $900,000 a year, range $750,000 to $1.1 million. You did a second non-ACGME fellowship in structural heart at age 36, another year on a fellow stipend, another relocation. Your wife stayed with you through that one. The case is a TAVR, 84-year-old woman. The surgical mortality of an open chest aortic valve replacement at her age and frailty score is 8%. She would not wake up. You access the femoral artery in the hybrid operating room. You advance the prosthetic valve over a wire, up the femoral, up the iliac, up the aorta, into her diseased native valve. Cardiac surgery is scrubbed in standby 10 feet from your shoulder in case you need to convert to open. You position the valve under fluoroscopy and transesophageal echo guidance. You inflate the balloon. The valve opens. Her aortic gradient drops from 52 millimeters of mercury to 5. Her heart sees a normal valve for the first time in 8 years. She walks out of the hospital in 2 days. Her chest was never opened. The radiation badge above your collar reads higher every quarter. Your back hurts in the morning before the apron goes on. You started physical therapy 2 years ago and you have not stopped. The apron weight has been there for 8,000 hours. 20% of Cath lab workers develop chronic back, neck, or hip pain. You are now in that 20%. You have a mental count of the patients you didn't save. The list is in a folder on your laptop you do not show anyone. In year 9, the academic center 2 hours away sends you a CTO case. Their team couldn't cross the lesion. 68-year-old man, ex-smoker, 3 previous PCIs. The right coronary has been 100% occluded for at least 4 years. You go retrograde, through the left side of the heart, through a collateral, into the back end of the occluded vessel. The case takes 4 hours. You cross the wire, you stent. The patient walks out 2 days later. Your back will not stop hurting for a week. The hospital Christmas party is the second Friday of December. You are on backup call. You drink a club soda with lime. The chief of cardiology on first call drinks 2 glasses of wine. You watch him drink them. Your wife loves you, and she still asks how your day was. You answer fine. You do not tell her about the 29-year-old patient last Wednesday whose heart you couldn't restart. You are 48 years old. The fellowship director who trained you retires this December. He thought he had until 65. Level 7, Cath lab director. $1.2 million a year, range $900,000 to $1.5 million plus. Clinical compensation, administrative stipend, equity in the ambulatory surgical center the practice owns, and industry consulting income disclosed under the Sunshine Act. 7 p.m. at the airport. Tomorrow morning, you are proctoring a newly credentialed interventional cardiologist in Indianapolis, her first independent Watchman case. The device clips off the left atrial appendage to prevent stroke. You have done 600 of them. She has done 12 under supervision. You order a coffee at the gate. You read her case briefing on your phone. The patient is 74, persistent atrial fibrillation, contraindication to long-term anticoagulation because of a prior gastrointestinal bleed. Your phone has the Cath lab group chat from your home hospital. 2 STEMIs since you left this morning, both in by 90 minutes. Your team handled it. Sunday morning, 43 results in your inbox, 3 echoes, 2 stress tests. The coffee is cold by the time you get to the bottom of the list. Your office wall has 37 framed photos, patients you operated on sent by their families 20 years of Christmas cards. The third one from the left is the 71-year-old grandmother from your first independent STEMI as a junior attending. She sent the photo of her granddaughter's high school graduation last May. The granddaughter is now 17. The youngest of the patients in those photos is now your age the year you finished the Interventional Cardiology Fellowship. You don't take overnight STEMI call anymore. The group voted on it last year. Operators over 55 rotate out of overnight rotation. The procedures are still yours when you scrub in. Your back will not let you do 4-hour cases anymore. The TAVR you did this morning was a redo on a patient you operated on 12 years ago. She is now 96. Her daughter brought you a card and a Tupperware of homemade lemon bars. Tomorrow, Indianapolis. Thursday, a TCT advisory board call. You are deciding. The phone vibrates, STEMI alert from your home hospital. You are not on call. You are 61 years old. The Cath lab is on the second floor of the hospital you have walked into for 33 years. A STEMI activates at 11 p.m. Anterior, 100% LAD, 68-year-old man, 2 children at his bedside. You are not on call tonight. The fellow takes it. PGY7. You stand outside the lab watching the angiogram on the monitor through the leaded glass window. She wires the lesion on the second attempt. She inflates the balloon. The ST segments on the monitor fall back to baseline. The man's wife sits in the waiting room. She does not know any of it yet. The fellow doesn't see you. You don't go in. The wire crossed. The vessel opened. The man's heart muscle survived. It did not need to be your hands. You walk back to the call room. Tomorrow you will write the recommendation letter for the structural fellowship she applied to. The clock on the wall reads 11:48 p.m. Down the hall, the Cath lab door opens. The fellow walks out, apron still on her shoulders, headed toward the waiting room. The wire is on the back table.